So welcome, and I look forward to another great year with you. So it is now my great pleasure to introduce Dr. Tim Bhattachyrra, who will kick us off. Tim graduated from Northwestern University, attended medical school at Washington University in St. Louis, did his orthopedic surgery residency at Boston University with a trauma fellowship at Mass General. He then became an attending orthopedic surgeon at MGH. He moved down here in 2008, down here being Washington, D.C. Thank you for your tax dollars, where he serves as director of orthopedic trauma at Suburban Hospital. And he also is head of clinical and investigative orthopedics at NIH/NIAMS. So it's particularly exciting for me as an orthopod to introduce yet another orthopod. And he has been named one of the best doctors in America. So it's with great pleasure that we bring to you Dr. Tim Bhattachyrra. Thank you, Tim, for being with us today.
Thank you, Lori. I don't think I can live up to that, but I will try. Let me see if I can get this screen to share. Okay, so we're going to talk about melorheostosis, and I have 46 slides to get through in 28 minutes, so let's get right into it. I don't have anything to disclose. I want to tell you a little bit about this disease, melorheostosis, some of the background, the clinical characteristics, and just a quick review of some of the science out there. I want to talk about the study that we're doing here at NIH here in Bethesda, and it's a really multidisciplinary study. We're going to go over some genetics, we're going to cross into radiology, pathology, some basic science, some bone biology. There's something for everyone there. I want to talk to you about what we think is the major cause for melorheostosis, which is a somatic mutation. We'll talk a little bit about management and how the cases present, and I really want to try to finish on time. So melorheostosis is a rare bone dysostosis. It has been likened to dripping candle wax, and this is a very classic X-ray. These X-rays are fascinating. It's as if someone had, this is an X-ray of a hand, obviously, and it's as if someone had poured hot wax on the bone, and it dripped down the skeleton. These are fascinating X-rays because you can see here that the melorheostosis, is here on the ulna, and then it skips the joint, and then shows up again here in the central ray. Some of it is here on the fourth metacarpal. It skips the phalanx and then shows up again. So it has a fascinating distribution. What do we know about this disease? It's pretty rare, about 1 in a million, we think is the epidemiology. It tends to present in adulthood, sort of around the age of 20 or 25 or so. Patients present with pain, deformity, contracture, limb length discrepancy, and they often have this thickened scleroderma-like skin. And they're really speaking, there is no known treatment. For us, the most common presentation we see is that someone has a minor trauma, an ankle sprain or something like that, and they get an X-ray, and it's an incidental finding on the X-ray that they have melorheostosis somewhere. That's by far the most common presentation that we see. So melorheostosis comes in different flavors. There is the classic pattern. This is the dripping candle wax phenomenon, where you have this exuberant, almost exophytic bone, usually on the cortical side, and it has this fluffy pattern, this characteristic candle wax pattern. This often, for some reason, shows up on tests a lot. I have no idea why. There's another, so it comes in a couple other flavors. There's an osteoma-like pattern, where the increased bone formation is confined to the inside of the bone. And then there's this MO type pattern where the melorheostosis seems almost always all in the soft tissue there. I have to point out this case report from 2001, which is just a case series of, and it's proved to be quite prescient. Had a lot of observations and insights in there. So the lowly case report can be very powerful. So there have been a couple genetic studies for melorheostosis, and it gets a little bit confusing. So let me just take you through this. So there is a condition called osteopoikilosis. This is a classic disease where you have this spotted bone disease. You have occasional islands of bone. This disease, osteopoikilosis, is familial, tends to run in the families. And this one we know is caused by a germline mutation in this gene LEMD3, and this we've known since 2003. Now there are some patients with osteopoikilosis who, on certain X-rays, will have evidence of melorheostosis. They'll have some of the flowing bone there, and this is osteopoikilosis with melorheostosis. This also tends to run in families. And we know from Stephen Mum and Dr. White that this condition is caused by a germline mutation in LEMD3. Now, the more common condition actually is sporadic melorheostosis. So it doesn't really run in the families. It's a random occurrence. And this condition, which is much more common, sporadic melorheostosis, is not caused by a germline mutation in LEMD3. These patients don't have that. That's been shown in 2 separate studies. So just to be clear, osteopoikilosis with melorheostosis, LEMD3, but the more common sporadic melorheostosis, they do not have germline mutations in LEMD3. LEMD3 is a nuclear membrane protein. It does something in the TGF pathway. We don't know too much about it. So what have I told you so far? So melorheostosis, it has this peculiar anatomic distribution. And it's the epidemiology, it's quite random. It tends to be sporadic. The sporadic patients, they do not have a mutation in the LEMD3, and this doesn't run in families. Here at NIH, we've been working for several years on this prospective study, and I want to tell you a little bit about it because I can see there are many people here working rare bone, and maybe it be helpful for you. So we started the study almost 7-8 years ago, and we recruited patients to come to Bethesda, come to the clinical center, and we put them through a standardized workup, physical exam, radiographs, some standardized testing, and then we made them see all our friends. We got dermatology consults and physical therapy consults and neurology consults, and the goal was to study the natural history and accumulate some clinical data. And then in selected patients, we offered, after informed consent, to do bone biopsies. So for patients that were willing to undergo a bone biopsy, we would take them to the OR. We would take the melorheostotic bone from the affected side, and we'd also take a control sample from the unaffected side. And then after extracting those 2 samples of bone, we would extract the DNA, and we sent that off for whole exome sequencing. And then the bone samples were sent for histology off to our friends in Austria. And Dr. Marini in her lab took the bone, grew out the osteoblasts for functional studies. So we were lucky to have great support from the Melorheostosis Association, and we were shocked to see so many patients come from 3 different continents and several countries, and really were quite pleased. So what do we find? Well, first of all, for us, the key finding for melorheostosis is that it's very hot on the bone scan. It's very hot on our PET CT scan. So here you can see a clinical image with the enlarged limb here, the lower limb, and for comparison, the normal side. And then this is the lateral X-ray of the tibia. You can see the knee here. You can see the foot down there. And then again, this is this exuberant bone formation, this Canawex classic bone formation for melorheostosis. And then on the PET CT scan, you can see that it's blazing hot, indicating that there's a lot of blood flow, there's a lot of bone turnover. Here in this cross-sectional image, here's your normal tibia, basically shaped like a triangle. And here's the affected melorheostosis growing significantly on the outside of the cortical bone and a little bit of on endosteal side as well. And you can see the fibula right there, totally spared. These patients had, a lot of them had dermatological findings, and they have this sort of increased pigmentation, this redness that can be seen. And I don't know if it projects here, but if you can see the the increased pigmentation, it kind of has a border. It just sort of stops over the area where the Melorheostosis is. These are 2 different patients, by the way. What do we find when we did the histology? Well, here's a sample of normal bone, dense cortical bone here, and this is a sample of affected bone. And what you see is we see increased Haversian canals, and we see this abundant osteoid formation. You can see it staining red here. The osteoid is just the unmineralized bone matrix that's being laid down, and it just hasn't had a chance to mineralize yet. But we see a massive amount of osteoid formation on the affected side. So on the surface of the bone, you can see that we have quite a bit of lamellar bone on the surface of the bone, laying down thick there. And then deeper, we see a more woven bone with irregular remodeling. Again, here you have the unaffected bone, and then the affected bone with the marked osteoid formation and increased blood vessels, increased blood flow. On this stain, here's an unaffected Haversian canal, if you will. And here on the affected side, you can see the osteoblasts just lining up on the endosteal surface of the bone. You can see them plump, just getting ready to lay down that osteoid. The osteoblasts are obviously up to something on the affected side. So of the 15 patients who had undergone bone biopsies at that time, 8 of them turned out to have mutations in the same gene. And this is the MAP2K1 gene, which is involved in the ERK pathway. So you can see here that the unaffected bone did not have any mutations, but they had varying levels of mutation burden in the affected bone. And importantly, the blood was totally negative for this mutation. So this shows us that it's a somatic mutation. It's not a germline mutation. It's only present on the affected side. So it's so interesting. The patients are very different. Their x-rays are very different, but their mutations are tightly clustered. So of these 8 patients, they had one of mutations in one of 2 residues in this MAP2K1 gene. Just 3 base pairs, just two base pairs apart here in this area. Now this gene, this MAP2K1 gene, which encodes this MEK kinase, it's known to play a role in cell proliferation, and it's very common in cancers, particularly colon cancer. So there's a lot known about this gene, and this mutation is all in the negative regulatory helix. So if you have this mutation, it tends to turn on this the MEK protein. So just briefly here, so the mutation here is in the MEK protein, which is in the ERK pathway. And we know from Dr. Marini's tests in the lab that this is an activating mutation. If you take the affected cells and you stimulate them, you get abundant expression of the downstream protein here, the ERK1. Just very quickly here, we also were able to see this by immunohistochemistry. So this is colon cancer. Colon cancer has high percentages of patients with MEK mutations, and that stains brown for the positive control. Here's normal bone, very little MAP2K staining in the normal bone, the unaffected side. But in the Melorheostotic bone, you can see abundant staining in the osteoblasts, which are positive for mutated MEK. And zooming in, you can see that the osteoblasts, not every one of them is positive, so it's definitely a somatic mutation. And we were lucky enough to catch an osteoclast here. And as you can see, the osteoclast is totally negative. So some other findings, the overlying skin, if you have skin changes, we were able to find a mutation in the skin itself. 7 of the 8 patients that we tested had MAP2K1 mutations in the skin. We have some data that the bone scan, we think helps us quantify the disease burden. The patients with more uptake on the bone scan tended to have higher, or tended to have worse functioning scores. And I'll talk to you a little bit later about surgical debulking. So I mentioned that Melorheostosis has different flavors. So for the patients that have the MAP2K1 mutation, 87% of them had this classic radiographic distribution. So we think the radiographs provide a clue into what the mutation status is going to be. Okay, so what about these other patients with this osteoma-like pattern? We think of this, it's called osteoma-like, but we prefer the term endosteal. These patients have melorheostosis, but it all is inside the bone. It's all confined to the intracortical compartment, if you will. So here's an x-ray. You can see the melorheostosis bone coming down the humerus, skipping the joint again, progressing through the radius, skipping the joint, and then into the capitate there, and progressing through the hand again. These patients do not have skin findings. The skin is totally normal. Again, the bone is hot on the PET CT scan, which helps you confirm the diagnosis. So these patients with the endosteal pattern, we found 4 of them, and they had mutations in a different gene, which is SMAD3. So here's a couple more x-rays here. Again, more of an endosteal pattern. There's increased bone formation inside the cortex. This is a tibia here on the lateral x-ray. Again, you have the dripping phenomenon, but it's all inside the bone. These patients have different histology. Just to be clear, the histology here, you have dense cortical bone, but no osteoid formation. There's no red here. So they have very thick cortices. You have the whorled pattern, the woven pattern, but no osteoid formation. So it's a totally different disease. So what to say about the clinical management? So, you know, for patients with melorheostosis, the treatment is largely symptomatic treatment. Things that we've seen that have helped very clearly are physical therapy is very helpful. We want patients to keep moving, to remain active. The patients that move more tend to have less symptoms. In terms of pain management, we prefer anti-inflammatory meds. So there's a little bit of disagreement in the literature there. Some people recommend bisphosphonates for melorheostosis. Our experience with that has not been as successful. So we don't usually prescribe bisphosphonates for patients with melorheostosis. And the occasional patient, if they have bridging bone or going across the joint, we think surgery is helpful. You know, one major thing we learned from this study, which we think is applicable for other conditions, is that you know, it's very important not to ignore your general health if you have a rare bone disease. We had a couple patients come in with uncontrolled hypertension. We had a couple patients come in with uncontrolled diabetes. We had a patient come in with B12 deficiency and a positive Romberg sign. So obviously those aren't my areas of expertise, but one thing we notice is that, you know, people tend to blame every symptom on their rare bone disease, but there are other very treatable conditions going on that can be going on as well. So had a lot of help with the study, and I have to give a shout out to Dr. Jha, our fellow, who got this all going several years ago, and has written a lot of the key papers here. Of course, Dr. Marini for the basic science, and Hesiog Kang, who did a lot of the basic science work. And this is our ever-growing team here at NIH. And I'd stop there, and before I go into the cases.
Tim, that was spectacular. Thank you very, very much.
Hey, not bad. 27.
All right, well done, because we certainly want to have time to chat